Welcome everyone to the Maddie Revolt's Vision 2025 series of patient and family educational sessions on bone marrow failure syndromes. My name is Jaya Soma and I'm the project manager of the Centre of Research Excellence in Bone Marrow Biology here at Maddie's Vision. Before we start, I would like to acknowledge the traditional owners of the land on which we are meeting. I would also like to pay my respects to their elders past and present and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. As many of you know, Maddie's Vision is the only organisation in Australia driving bone marrow failure syndrome research, advocacy, education and support for patients and families. We've now funded $9.3 million across 36 cutting-edge research projects and have multidisciplinary collaborations in place with 24 leading research institutes across Australia and internationally. We are the source of support for bone marrow failure syndrome patients and family members through our Tally Support Service and peer support program. We have now supported 130 patients and families nationally and invite any of you here tonight who have not connected with these services to please reach out. We are here for you when you need us. We would like to share some breaking news that we have yesterday. The Honourable Peter Dutton MP, Leader of the Opposition, announced that an elected Dutton coalition government will invest $3 million over 3 years to support Maddie Revolt's vision to grow our research initiatives and continue patient and family support services. We are incredibly grateful to the Coalition for making this funding commitment, and it is such an exciting response to all our advocacy work. We are really thrilled for our program this evening, and it will feature presentations from leading experts, Associate Professors Adam Nelson and Wayne Crismani, who will discuss Fanconi Anaemia past, present and future. Following their presentations, we'll have a 30-minute question and answer session, and we're really grateful to everyone who submitted questions prior to today, and our speakers will endeavour to address all of these in their presentations. However, if you would like elaboration on certain topics, then please do let us know during the Q&A. I'm now delighted to introduce our first speaker, Associate Professor Wayne Crismani. Wayne is Laboratory Head of the DNA Repair and Recombination Laboratory at St. Vincent's Institute of Medical Research in Melbourne. I'll hand it over to you, Wayne. Thank you so much.
Thank you, Jaya. Does that look okay? Does this look okay, Jaya?
Looks great. Thanks, Wayne.
Thanks. Okay. All right, just got my eye on the time. All right, so thank you for this opportunity to speak. I'm going to do an abridged version of a talk that I did with a collaborator of mine, Oinika Valoya. We presented this in Charlotte last year in the US. And so I've just got her name up here acknowledging all the slides that I'm using from her that we sort of put together over the course of doing this presentation. And so it's about how we have approximately 100 years of experience in understanding elements of Fanconi anemia since it was first described. And so we talk a bit about the past, present, and future this evening. So starting off, as Jaya mentioned, I work at St. Vincent's Institute, and I think it's important to point out that I am a researcher. I am not a medical doctor. I'm a PhD doctor, not a medical one. And this is my team at St. Vincent's Institute, and everyone that you can see here, they work on Fanconi anemia. Before we get into talking about this condition specifically, I just want to give a very brief overview of DNA and genetics and how it's relevant to Fanconi anemia. I think that if you're on this call, you probably already have a sense of this, but I think it's best not to assume, and just do a tiny bit of background. So our DNA is like a blueprint that helps define a lot of who we are. Definitely not everything, but quite a bit. And so inside our body, we're made up of many trillions of cells. And then within cells, there's a nucleus that have our DNA, which is sort of condensed down into 46 chromosomes. And we have this ladder of information that's sort of drawn here. And we have billions of these little ladders, pieces of information that sort of compact into things called genes, which I'm sure you're aware of, but just wanted to give a bit of an overview of this. And then something that's important to consider with Fanconi anemia is that, our DNA is being damaged all the time, no matter who we are. And whether it's a bit of ultraviolet light from the sun, which is largely unavoidable, just normal metabolism, being alive, things like alcohol and cigarettes increase the amount of damage to our DNA. And then also chemotherapeutics cause DNA damage as well. And that might be something that ironically can have therapeutic benefit. But the point is that we're exposed to DNA damage all the time. Someone who has Fanconi anemia, the cells in their body have a harder time repairing the DNA damage than someone who doesn't have Fanconi anemia. And generally, the way that Fanconi anemia is inherited is something which is called autosomal recessive. And what that means for most of the Fanconi genes is that the two parents of someone with FA, they are carriers, often unknowingly. And there's sort of on average, 1 out of the 4 children here in this diagram can be affected by Fanconi anemia. 2 out of 4, or 50% of them, will become carriers, and 1 out of 4 is unaffected. And of course, there are exceptions to this. Some of you might be aware of, there's an X-linked version of this. And there's also one other very uncommon dominant subtype, but roughly 98% of people affected by Fanconi anemia have this autosomal recessive pattern of inheritance. And so this condition was first described 98 years ago by a Swiss doctor called Guido Fanconi. And you can see in this drawing that he has done, it's a very good drawing of blood smears. The first time I saw it, I thought it was a photo. This is a drawing that he's done in his article about describing 3 brothers who all had very similar symptoms in this type of anemia that he described. And so on the left, you can see a blood smear from someone who is unaffected. And on the right, you can see a blood smear from one of the boys that shows less red blood cells. And so that was the first description, but we have come a long way since then. This is a photo taken about 6 years ago at an adult meeting in the US. And now there are more people in the world, more adults that have Fanconi anemia than children, which is a testament to the progress that has been made with medicine and research. And so I wanted to talk about a selection of good things that have happened over the last 30 or so years, some really impressive outcomes to do with Fanconi anemia or flow-on effects from other fields of medicine that have impacted people with FA in a positive way. So one of these is that there are hugely improved outcomes with respect to bone marrow transplants. And that's something that really started to change in the 90s with the introduction of something called fludarabine, which really promoted better outcomes. Then there are other things also that are important to know about Fanconi anemia, where there are things that have happened in the Fanconi field that have had a flow-on effect and had really positive effects for people with Fanconi anemia and other people in terms of medicine. So the first ever umbilical cord blood transplant was done for a patient with Fanconi anemia in France in 1989, and this person shown here, the recipient of that transplant, is doing well today. And now there are cord blood transplants done all around the world, thanks to something that was pioneered by the Fanconi anemia community. Similarly, the first ever person who was born, who was sort of chosen through IVF to be able to be a sibling of someone who had Fanconi anemia, they had a sibling through IVF with their parents who was selected as an embryo to be a tissue type match so that they could have a donor for their sister shown here. And then beyond medicine, there's also just the basic biology, which is really important for us to understand to be able to deliver improved outcomes. One is understanding why does the bone marrow fail in Fanconi anemia. This is something that's understood now. Identifying all of the genes that are involved in what causes Fanconi anemia. This is something that scientists have worked out and doctors working together. And then also this connection between cancer in the general population and Fanconi anemia. And there's also a lot of really good things happening with clinical trials around the world for Fanconi anemia. One is the gene therapy clinical trial that has sites in Spain and the US and the UK now. There's also a clinical trial for head and neck cancer, which is happening in Spain with a drug called afatinib. I think we might be hearing a little bit about quercetin, perhaps, or metformin from Adam afterwards. And then also cancer screening has been shown to be beneficial in both the blood and the mouth. So the diagnosis of FA can happen at any point in life, but it's sort of skewed towards the earlier years. And so it can occur right around the time of birth due to physical differences that might trigger a suspicion of Fanconi anemia. And then bone marrow failure is another one that can lead to a diagnosis. And in Australia, much like many other Western countries, the average age of diagnosis of FA peaks around this age of 7 when bone marrow failure can occur. And then other reasons why there might be a diagnosis could be something like leukemia or a solid cancer in young adulthood. But the point of these sort of like overlapping circles that we have shown here is that, you know, some of these things are common in Fanconi anemia, but not every patient looks the same or experiences the same symptoms. And this is really important to understand. It's not completely deterministic. And it also explains why diagnosis can be very hard because, again, not every patient looks the same. And so I'm sure you'll have appreciation of some of the classical features of Fanconi anemia. And I should point out, by the way, that all of the photos that I show tonight are shown with permission. This girl here you can see the upper limb physical differences that she has. And so this is one of the characteristic features of Fanconi anemia, but also many other conditions as well. It's not specific to Fanconi anemia. So there is this acronym. I'm not going to read out all of these things, but this acronym VARTA syndrome is often used as something that can come before the diagnosis of Fanconi anemia, where someone can, you know, they have physical differences that are from these different categories. And the more that there are of these, the more that it can trigger suspicion of something underlying like Fanconi anemia, which is the reason for these differences. But then, so the VARTA syndrome is something which is a little bit more general, but points to a genetic condition. Then going down and being more specific about Fanconi anemia, there was an acronym that was created by some epidemiologists at the NIH, National Institutes of Health in the US, at the National Cancer Institute, which is called PHENOS. And again, you've got what this acronym stands for here. And so this is a subset of things that for people who have both VARTA syndrome and Fanconi anemia, this is something that occurs more often in the group of VARTA people with Fanconi anemia than the VARTA people who don't have Fanconi anemia. So it's something that can be relatively simple and less complicated in terms of like helping to sort of progress the suspicion of Fanconi anemia or to rule it out. And as I mentioned before, you know, not every patient looks the same. And so, you know, there's this thing about VARTA syndrome where there's about 8 different features that can make up that acronym of VARTA. And you can see here an example at 2 ends of this spectrum where, you know, around 25 to 40% of people with FA have no physical outward features of Fanconi anemia, and then other people have many. And this is just something that is illustrating that. And something that we really don't talk about enough in sort of research, but is getting more and more attention, is the fact that, you know, there is a lot of stigma associated with the physical differences that come with many cases of Fanconi anemia, and that can be associated with, you know, real impacts on well-being. And there was a recent presentation in the US about this, where they were saying that, you know, there are a number of people who, when interviewed with Fanconi anemia, show the clinical signs of post-traumatic stress disorder and depression. And that was, you know, the inference was that was associated with the physical differences. And so, you know, this is something that we have set out to address in Australia. We are doing a research study. So this is Fanconi Anemia Support Australasia. in collaboration with my research institute and Laura Forrest at Peter MacCallum Cancer Centre. If you're interested, you can register your interest. You can register your interest to do an interview-based study about Fanconi anemia. This is anonymous, but one reason that you might consider doing this is that this is a way that we can take these real the psychosocial issues that come with having FA. It's a rigorous way that these scientists who we're collaborating with can document these. And this is something that we can show to funding bodies to say, these are real issues that people face. This is not anecdotal. It was done in the best scientific way, doing these interviews. So if you're interested, please feel free to reach out, because we'd like to hear from you and define what are the common experiences in particular. I'm almost done. I was just going to mention briefly that there's a different spectrum of the clinical presentation of Fanconi anemia. You don't need to worry about the numbers at the bottom here to do with blood. But the point is that there is what is the sort of considered the textbook version of Fanconi anemia, which is bone marrow failure and some specific physical differences. But then there are other groups of people who have genes affected in the BRCA1, BRCA2, and PALB2 genes. And this is what some people refer to as the early cancer phenotype. And so the people in this group, they tend to have less bone marrow failure than the people in the traditional, the classical Fanconi anemia in this other group on the left. There are also people who are diagnosed as adults that can have a slightly different presentation. And then there's also this group of women with Fanconi anemia who conceive naturally, and they tend to have a different profile, again, from the other groups that we are talking about here. So there's a lot of overlapping similarities, things like, predisposition to bone marrow failure and the underlying DNA repair issues, but there's also many differences between all the individuals. Also, something that I think is important to appreciate is that the condition is not entirely deterministic. And so I want to show you what I mean by that. So we have some siblings here who they both have Fanconi anemia. Because they're siblings, they have the same Fanconi gene affected, but they have quite a different presentation. And it's just showing that not everything is determined by the Fanconi gene that's affected in these two, this brother and sister. And you could say, okay, but one is a boy and one is a girl. What about that? That's a difference between them. So if we push this to the extreme, there are two, here we have identical twins. They both have Fanconi anemia, and people who are identical twins are more or less genetically identical. And even with this being effectively identical genetically, you can see differences here between them when you look at their hands. So it shows that there are things which are going to be common in Fanconi anemia. Common things are to do with bone marrow failure issues with the kidneys and so on, but not everything is predetermined. So there's a lot of research happening in Australia and around the world. I think that I'll just move on in the interest of time because we can come to this in the Q&A. I just wanted to point out two things very quickly. Some of the findings that we have done with a research project that's coming to completion shortly, and that is about what we have found in terms of the genetics of people in Australia and New Zealand with Fanconi anemia. You can see that we have broken this down into sort of the percentages of which genes are affected in the people involved in this study. And so what you can see in the orange dots are the people from the Australia-New Zealand study that we led. And most people, on average, the gene called FANK-A is affected. But then as you go down through the list, you do see some differences with how the genes that we see affected in Australia and New Zealand. So the second most common was FANK-D2, which is quite different from the US, where we've seen no cases of that in Australia in our study. But in the US, this is the second most prevalent gene to be affected. And this is something that has also been seen when different countries do these studies around the world. They do find similarities, but differences. And I think that this is something which is important for us to consider when it comes to things like gene therapy efforts going forward into the future, because what maybe suits the US doesn't necessarily suit us. We have seen things that are more similar to some Western European countries, but no matter where you do this study, you're going to find differences. We did find that the most common age of diagnosis in Australia is 7, which is similar to what's seen in other countries. Something that was very important that we found was that more testing in like different, we saw which states tested more in Australia than others. And in the states that test more per head of population, they detect more cases, which means that Fanconi anemia is probably underdiagnosed in Australia. There's a slight bias towards testing boys. Doesn't mean that many girls were tested, but there is a bias definitely towards boys. And after all of that, around 4 new cases are detected in Australia on average per year. Now, just very quickly, talking briefly about cancer in FA. This is going to be very brief, but I just want to point out, and you probably know already, that there are less treatment options for cancer, which is a big problem in FA. But something just to consider if it becomes relevant to you is that there's something called the Virtual Tumor Board that the Fanconi Cancer Foundation offers for free, which is a group of experts familiar with treatment of cancer in Fanconi anemia. This is US-based, but they will consider cases from anywhere in the world for free. I'm sure Adam can speak to this more, and there would be lots of multidisciplinary meetings for cases for people in Australia, but just to remember that this is a service that exists for anyone anywhere in the world affected by FA. Also, we run a study about early detection of head and neck cancer. It's non-invasive oral screening. I'm sure that many of you are familiar with trips to the head and neck specialist for surveillance, but this is less invasive, and it's something that we're happy to talk about if you're interested. This is the same registration of interest form as previously. And very last is just that there is an app that's been developed by the German team, Eunike, who I mentioned earlier, which is a free app that you can find in Apple and Android Google Play stores. If you just put the words FA exam as one word, you can search for it. It's free. The data stays on your phone, but it's just an app that you can use for self-surveillance for lesions in the mouth, which can be useful basically to see if they have been changing or staying the same over time. So that documentation has been something that's been found to be very useful. All right, I'm going to leave it there, and I just want to acknowledge all the people in my team, and also there's 2 large teams at St. Vincent's Institute where I work that focus purely on Fanconi anemia, my team and the team of Andrew Deans, so feel free to reach out anytime, and also consider visiting Fanconi Anemia Support Australasia. All right, thank you.
Thanks so much, Wayne. That was an incredibly informative presentation. Now I'd like to introduce Associate Professor Adam Nelson. Adam is the Director of Bone Marrow Transplant and Cellular Therapy at the Kids Cancer Centre at the Sydney Children's Hospital. Thank you, Adam.
Yeah, and thanks, Wayne, for a very comprehensive overview of FA. So I was just going to try and share a couple of clinical updates that might be relevant for some of you, and some of you may have seen these in various forms in other presentations. So Wayne has quite nicely covered the genetics of FA, so I won't go over that. And as Wayne has said, some of the manifestations we see in patients who have Fanconi anemia is marrow failure, but also this propensity, as Wayne mentioned, for second cancer development over time, because we've gotten much better at curing their marrow failure through advances in transplantation. And so now our focus is switching over to how can we prevent or treat cancer as it develops over time. Now, one of the things that we had noticed in patients with FA is that there seemed to be quite a significant distribution of children and young adults who are either smaller or bigger than their counterparts. And so rather than having a nice distribution where you see these are the BMI centiles where everyone fits pretty roughly together along a curve, we saw 2 distinct populations and wondered why some children had a lot of difficulty gaining weight and other children had no problem at all. And so I think, this is relevant and known to many of you who either know someone or suffer with FA yourself, that children are much smaller than their non-FA counterparts, and that gaining weight can be extremely challenging, if not impossible, despite lots of things like extra calories, either with protein drinks or supplementation, either through the normal mechanisms or by inserting things like nasogastric tubes or peg feeding tubes. Doesn't seem to help put on body size. And this can cause significant distress, not only for the patients, but also the family members who feel like they're underfeeding their children and having trouble making sure that they gain size. And that can be, especially true for some people who may require a bone marrow transplant, and some centres may have rules about how big you need to be to undergo a transplant, so that can be quite stressful. We also know that that muscle mass is significantly reduced in patients with FA, even despite calorie supplementation and exercise programs. And so we sort of wondered why that was occurring. When we look at the measurements throughout the body, we can see that the groups in black are patients without FA, and the groups in red are patients with FA. And you can see in things like when we look at skeletal muscle mass, and muscle circumference and grip strength, these are all much lower in patients with FA compared to the non-FA counterparts. So we wanted to understand, could there be a reason for this? And so we did what's called a metabolomic study, where we give patients a sugary drink and then collect samples of blood and urine at defined time points after they've ingested this sugary drink to look at where these glucose molecules are going in the metabolic pathway. That might give us some clue as to why patients have difficulty gaining weight and putting on muscle. And so what we can see here is that, again, the FA patients are in the red down the bottom and non-FA patients in the top. And what I wanted to show you is that the basal metabolic rate, so how many calories your body needs per day, is different at the baseline. So 1,400 in patients without FA compared to 1,000 in the FA population. So at baseline, these patients seem to need less calories than their non-FA counterparts. But this changes actually after you give them some sort of metabolic stimulus, such as this glucose drink. You can see that the caloric requirements drop significantly, so down to sort of almost starvation levels. And so this is telling us that the body has a maladaptive process when it receives calories. We also looked at different hormone levels, and what we can see, again, the FA patients in red, that there was differences in insulin and cortisol, which are part of your body's response to calories. And so there's an abnormal hormonal signaling process that's going on in patients with FA, which might explain some of the reasons they have difficulty gaining weight. And this is true for other markers of the metabolic response, in particular things like GIP and pancreatic polypeptide, which are involved in absorption of the nutrients. So you can see that these levels of these hormones are elevated in patients with FA, which may affect the way the body absorbs these nutrients and then goes on to process them. And ghrelin, which you may have heard of, is known as the hunger hormone in the blood, so it controls how our appetite is and how hungry we get, and that's certainly what some of the newer drugs try to act on for weight loss. You can see that it's markedly absent in the FA patients, those patients in red, compared to the general population. And so we sort of think that this leads to this setup where people feel less hungry, they're unable to process nutrients effectively, they're unable to convert the nutrients into the building blocks for muscle, and that affects the inability for these patients to be able to gain good weight and significant muscle mass. So I guess what can we do about it? We think, well, perhaps smaller meals more frequently might be helpful to try and avoid those peaks and troughs of how those hormones respond to a glucose load. We think that protein is important because we know that the protein processing in the body is difficult in patients with FA, so trying to maximize protein sources might be useful. And again, maybe some supplements of certain vitamins and minerals might be useful as well, but there's some ongoing work to try and elucidate that further. As Wayne alluded to, I wanted to talk about quercetin, which is something that we worked on for a while whilst I was overseas. We saw that in mouse models that quercetin improves the stem cell healthiness of the stem cells in the bone marrow compartment, and that cells that are treated with quercetin in the mice don't go on to develop leukemia. So we thought this was a promising target that might either improve or delay the onset for marrow failure, and then in a secondary study try and either reduce or delay the onset of cancer development in patients with FA. And so what is quercetin? Well, it's a naturally occurring sort of antioxidant that's rich in things like onions, tea, red wine, and is a common supplement found in many different multivitamin preparations. And it's really inexpensive and easy to take either on its own, in gummy form, or mixed in with things like yogurt or ice cream or things like that. And so what we did was take different patients with FA and give them increasing doses of quercetin to see what happened. And basically, once we got to the maximum tolerated dose, we looked at markers of stress on the bone marrow cells to see if anything changed. And so this was done on a number of patients, but ultimately we enrolled about 20 patients to see what effects this had on their peripheral blood numbers and also on what was happening in the bone marrow. And so what we saw that there was a significant reduction in something called reactive oxygen species, or the amount of sort of stress that these cells are under. So you can see here at baseline, we saw the ROS levels decrease after treatment with quercetin, and that was quite significant. The drug itself was well tolerated, and in about a quarter of patients also resulted in weight gain, which is not a bad side effect, as I've mentioned, for patients who sometimes struggle to gain adequate weight. When we looked at the effects on the blood counts, again, we didn't expect this to be a game changer, but what we saw was perhaps a slight increase in platelets over time, but in the context of knowing that blood counts can oscillate over time as well. And we saw no changes in the neutrophil count, and perhaps I haven't shown here, but a slight decrease in hemoglobin, but again, nothing significant in terms of a decrease. Importantly, when we looked down the bone marrow under the microscope, we saw no changes in how bad the cells were behaving. So these cells had no increase in dysplasia or markers that they were transforming into either leukemia or pre-leukemic conditions. So just to touch on transplant as well, because I'm a transplanter, as Wayne said, we've made huge gains in the way that we do the transplant for patients with Fanconi anemia with the introduction of fludarabine. We've also adapted the way we do transplant. So rather than a one-size-fits-all model for patients, we've really tried to adjust for what is happening for individual patients. So younger patients who just have marrow failure are getting less doses of chemotherapy compared to older patients who may have changes of malignancy going in the bone marrow. And the idea behind that is to try and reduce some of those effects that we see in children who are treated with chemotherapy, as Wayne had said previously. And so we've come a long way. If we look at the survival from transplant, we've got 93% survival for patients who are transplanted for marrow failure, which we think is pretty good. And over the last few years, we've tried to focus on patients who've developed either MDS or leukemia, because we knew that the outcomes for those patients were historically bad. And so what I'm pleased to share with you is that with those changes that we've made to how we do the transplant, previously our survival rates for patients who had MDS or leukemia were only 20%, but in our most recent cohort, we've been able to bring that up to 80%. And so I'll stop there and
a huge thank you to Wayne and Adam for your amazing presentations today and for offering your time to ask the questions that people would like to have addressed and really sharing all your knowledge with us. We'd like to thank everyone here for attending, and we do hope it's been informative and helpful to you and your families. We're so grateful for the questions you submitted in advance and for helping us shape the content tonight. Your lived experience is so vital for helping we ensure the work we do is tailored to your needs. So thank you. Again, Adam and Wayne, so grateful for your time and expertise that you've donated this evening. For everyone who did attend, we will be sending a short survey tomorrow, and we'd love your feedback as it does help inform how we can improve these events in the future. Tonight was the first of 4 patient and family sessions for 2025. So please do keep an eye out for the next event that we'll be holding in June. There will be a survey that we plan to send out. So if you have any ideas for future sessions, we'd love to know. And that does conclude the formalities for the evening. So thank you so much again. And we wish you a wonderful evening. And please do stay in touch. And yeah, please do get in touch with Wayne if you'd like to take part in that study. Happy to connect.